Now we'll discuss the principles of pediatric fracture treatment. Before we go on to the treatment principles, we should have a sound knowledge of remodeling potential in a growing bone, and the remaining growth potential in a younger age group is very important, and that is all the remodeling potential, but corrects the deformities. If you look at the graph, there is age on this x-axis and the deformity on the y-axis. Around birth, all the deformities they correct beyond the accepted level, and even they get normal with growing age. At later age, there is a decrease in the deformity with time passage, and deformity comes up in the level of acceptability. But at the level of maturity, the deformity remains the same, but it does not reaches the level of acceptability. And if you see on this yellow line, this is a remodeling potential which is decreasing with increasing age. So how the remodeling corrects the malalignment? If a fracture is united at an angle, then comes the role of remodeling. This is the shaft diaphyseal area, this is epiphysis, and this is epiphysis growth plate. What happens in the process of remodeling? There is a resorption of bone over the convex side, tensile side, and there is overgrowth. More bone is laid down over the compression side, the stress areas, and there is also different lines, the growth lines, which becomes asymmetrical, and then they realigns along the physis. Here is an X-rays with a fracture of the distal radius. There is a bayonet opposition. Red area shows the ends of the bone, but there is formation of new bone formation that is covering the bone edges and is going like this, and after a few months there is auto correction of the deformity, bayonet deformity, by the power of growth potential as well as with the process of remodeling. There are epiphyseal injuries. The epiphyseal injuries, how to diagnose these epiphyseal injuries and how to manage. These accounts most common injuries in children, 25%, and it's more common in males, and it's more common in upper limb as compared to lower limbs. Most heal well, rapidly with the good remodeling, and sometimes there is a growth arrest as well. So there are 6 types. The Salter-Harris type, Harris classification is for different types of physeal injuries. The type 1 is through the physis, straight through the physis. That denotes S stands for straight through the physis. Then is Salter-Harris type 2 that goes above the physis, above the physis. So then comes the Salter-Harris type 3 fracture. It goes lower to the is extending from the physis into the through the epiphysis. That is lower. So this is basically the mnemonic of Salter. TE is basically a fourth type of Salter-Harris type, and that is through everything. TE is through everything, to the metaphysis, to the physis, and through the epiphysis. So there's a Salter, and or is rammed this rammed through the physis. So last one is basically Salter-Harris type 6 injury, which is more grave injury. Which one is more commonly involved? So the type 2 injury is more common. It is in 75% of all the physeal injuries. It is above. And the lower is the second most common is the lower, that is Salter-Harris type 3 and Salter-Harris type 4 injuries, which accounts for 10% each in all the physeal injuries presenting in the trauma. So what is the importance of this classification? This is basically the growth arrest increases in this order, starting from Salter-Harris 1, it has a minimum or none of growth arrest, and it is increasing as the stage or the class of Salter-Harris type increases up to 6. There's a maximum growth arrest. So what is the treatment of metaphyseal fractures? Displaced fractures needs reduction and maintaining the reduction. Undisplaced fractures are more challenging because they affect the growth and they affect the direct the physeal growth, and there could be asymmetry developing with the undisplaced fractures. Here's an undisplaced fracture, and it has gone into the angular deformity. When you measure from the height, there will be a difference in the alignment. So there is asymmetrical growth. That asymmetrical growth could be iatrogenic or it could be biological reason for that, and there is sometimes, as far as the tibia is concerned, the medial grows faster than the lateral because of the more blood supply. What happens with the diaphyseal fracture? Diaphyseal fractures. Here you can see the diaphyseal fracture of the radius, and there is disruption of the distal radioulnar joint. This particular type of is basically the glazy fracture dislocation, and what you need to understand is the muscle forces which are displacing. This fragment is being displaced because of the action of the brachioradialis, and sometimes you consider the limits of acceptability in growing age. And the treatment principles, and you need to know the treatment principle of specific fracture like this glazy fracture dislocation needs reduction and fixation with plate. In summary, the close reduction is the mainstay of treatment in pediatric bone. Sometimes we need to reduce the fracture and fix it with some pins, plates, or intramedullary rods. Keeping remodeling in mind is the key to successful treatment of pediatric fractures. Sometimes we wait till the remodeling corrects their deformity, and sometimes you overcorrect the treatment, and there would be the worsening of the problem. But with the growing age, you should know the potential of growth and the correction of deformity. There are chances of some sort of deformities which correct automatically with growth. Make sure that all these knowledge which you have through these lectures would be applicable in your daily life to treat the pediatric age group patients in a good way. And thank you very much.